interesting stuff that I've been finding in my clinic and wanted to share. So yeah, I've called this lecture today we called it Fearing Endometriosis and Your Function. So I realized as I was driving, I said fearing, it means like, I was like, I wonder if people think it's endometriosis and fearing their function, but it's fearing endometriosis and then separately your function, just to be clear. So yeah, so kind of the objectives I want to accomplish today, just kind of like when you want to getting into a car, a stranger's car, you want to know who's driving and you want to know where you're going. So that's why a little Google Maps icon. So I want to give you basically the latest clinical evidence and evidence-informed knowledge today. I want to raise some questions about what it is currently going on, in perhaps some of you with endometriosis, and then I want to enrich your life with more knowledge, of course, and empower you with another option, or at least another option in your thought process of how you can address your endometriosis symptoms and your needs, and then walk out knowing that you have a different choice, whether you have a choice, whether you choose the passive one, and that's kind of like medicinal things or surgical things or not doing anything at all, or something active and proactive and getting therapy, getting exercises, and learning about how to be more aware of your body. So here's a little bit about me. So I've been practicing for over 10 years manual physical therapy. Basically what that is a little different than physical therapy where it's just exercises. It's a hands-on approach, and we use our hands to either free up scar tissue or and mobilize joints and get things moving along with understanding of biomechanics in general. And so I've created a niche specialty in this community for chronic pain. I do work with visceral being organ pain, so things like your stomach or your uterus in some cases. That's where I'm trying to free up those things so they move better within our system or within our body and the biomechanics there. And nerve pain is something I'm big into, and movement dysfunction. I think this is what I'd love to do for my whole life, is understand more movement dysfunction, get into more fitness, wellness, and injury prevention. But life has taken me into chronic pain population, and I found that's something very fascinating, and I love trying to tackle the problems that no one else wants to jump in and help. So I am currently, as the last time I checked, #1 on Yelp. I have great fortune of people Yelping me and having the most reviews in Southern California as a PT and in Orange County. I am one of 250 certified functional manual therapists within the Institute of Physical Art internationally. It's a very rigorous program, and so you can go on and talk about that for years and eons, but it's a great thing for my hand skills and observation skills. And so I've been able to learn under some of the top people in the world and call them my mentors. Great fortune. I've been able to also mentor and be an adjunct professor for the past year at Chapman University, and I'm clinical faculty over at San Diego State. Take students and get them to become new grad doctors of physical therapy. I've also been in my younger years. I actually have authored a book. I forgot to put that. I've authored a book, and we brought some Rehab the Mind and Revive the Body. I'm a blogger, so you can just stick my information in, and a health columnist for The Notice in Orange County. And I write about health and mind-body awareness, injury prevention. Those are my topics I like to address the most, as well as chronic pain. And then I've been featured on NPR a few years back on Tom Ashbrook's On Point to talk about things like CrossFit and whatnot. So, and then prior to beginning rehab my physical therapy, I think what created my hunger and interest in chronic pain was working for Dr. Gary Kaplan out in Washington, D.C. He's at the Kaplan Integrative Medical Center, where he's really known for Lyme disease, inflammation, and mold and neurotoxicity, long before people were even talking about it. So I had the great fortune to be in meetings with him and really understanding that and trying to figure that and how physical therapy can work together. So I've been just blessed to have a lot of just great guidance in my life, and want to bestow it to everyone that encounters me. So yeah, and so the next slide, this is about my clinic, Rehab and Revive Physical Therapy. This is my shameless plug here. We opened in 2011, and I started in my parents' garage after an incident with a former boss, which I can talk about another time. But basically, they were trying to commit insurance fraud, and I had to leave. So I started depressed, but I was like, okay, I'm going to do this on my own terms. And so then eventually the garage got too small, and then we moved to a little storefront. I had one room in 2012. And basically started in Tustin, and since then we've moved to 3 different locations, and now it's 2016. So we have right now what my practice is a fee for service, and what that means is that patients pay out of pocket initially, and then they go to their insurance and with a super bill and things like that. So just allows me for more time with the patient and quality care, and I believe it is the essence of those with chronic pain to have that intentional focus to get better. And so it's one-on-one with me so far, since I'm the only clinician there, and it's 45-minute treatments, and we currently have 4 private treatment rooms that I'm bouncing back from, back and forth from, and then so this is what we okay. So we do employ a unique style of therapy at Rehab and Revive, and this is over my kind of collaboration and commingling of all the things I've learned. Instead of saying the integrated systems model or the functional manual therapy, I realized there's like 6 main points that I really do address that I think people need to start looking at in the medical world. I think it's a different way of looking at things. So the first thing I do look at in my 6-point strategy is something is something called internal mobility, and what that is nerves and organs, the viscera and organs. So actually, I like to have you all stand up and just kind of get a little break from the chairs. But our organs do need to move, and they need to move either out of the way and not really collide with us. So we just kind of grab your stomach, and what you realize is if you just kind of just put palm here, and you should be able to kind of slide your tissue, if you let your stomach relax, if you slide your tissue up, down, around like a clock, and it really shouldn't feel restricted. It should be nice and mobile and fluid. And then, for those with endometriosis, even down to the bladder and uterus, you may see that things may not move quite as well. And so that's something we do want to address and free up, and we'll talk about a little bit more of that later. But, while you're standing, the next thing is what classically most therapists and other practitioners go for is your external mobility, is your connective tissues, your joints, your tendons, and your ligaments. And those they always want to free up, and you want to get stretches and all those things. But, you do need those. But I think I always use the analogy of if you have the sweater, right, and you're caught in the sweater and you're trying to rotate, wouldn't you say the sweater is also on the inside threading needs to rotate too. So everyone's so focused sometimes on the outside, of the shell versus the inside. So, so basically, if you want to take a look at the hip range of motion and things like that, for someone with endometriosis, you want to look at if they have enough range. So you should be able to get your knees up to about 100 and hips up to about 130 degrees or so, and that's helps kind of. What happens here is then the organs should move out of the way. If they're in the way, then you're going to collide, and it's going to really limit your mobility. So those are things I do kind of quickly assess in my clinic. But I think these 2 are, most therapists will more or less try to get after. And then what we want to go after next is what I call a neuromuscular reflex, or it's like and connectivity, and we want to retrain that. A lot of times. That you may have healed physically, guys like great athletes like Kobe Bryant or many athletes or people that sprained their ankle. Physically it's healed, but that neuromuscular connection hasn't been restored, that awareness, that mind-body connection. So we do manual techniques to really try to get that going again and get that synapse going. I used the analogy of, it's like AOL dial-up. You guys remember what that was like, and how I was trying to ping and connect, and sometimes these messages would drop. And when they do drop, and, that's when, you don't get the information, right? But now you have faster broadband, all these things, the bandwidth is much better. And so that's what we have in our neuromuscular system. We want to be able to restore that, reinstate that. And so, classically, even if therapists are doing this stuff, they're missing the greater picture, which is life things, right? And so I like to think about things as performance. So I have a lot of people that work at the desk, and I actually call them desk jockeys, DJs. So it's just like you're being a jockey on a horse, but it does take a lot of strength, in essence, to be able to sit statically, sleep statically, and stand statically. A lot of people aren't it's troubling for some. They can't fall asleep. They can't, they can't stay asleep. And those are things I like to think of still as performance in a little way. And then on top of that, you can sit, sorry. Yeah, you're like, what are you guys doing? Static and then dynamic performance, whether it's like carrying your baby or walking, running, vacuuming, climbing stairs. These need to progress, and we want to progress all patients over, in that direction. But I think the most important thing, and is you, the individual, is I do believe that being intentional with your needs and your goals, being able to understand your habits, the way you communicate, your fears, of course, and are ways that we can do to then empower and educate the population, the chronic pain population, whether it is endometriosis or headaches or TMJ or coccydynia. We're really trying to expand on that. So that is I believe the binding thread is you belong in all of these. And recently I was watching some kind of YouTube video on what was it? It was a YouTube. What was it? Where was it? Where are those? It'll come on top of me. It's just, dang, I can't remember off right now. But there's a picture, they're talking about rounds, regardless. It was doctors and rounds, and they're talking about things in an integrative and holistic way. And what I realized, and they flash this picture, and basically what is holistic now is a bunch of doctors in different disciplines sitting in a meeting room like this, and what's missing? The patient, right? So we want to think about that. The holistic part is you, and we do believe that this is the way to unlock your potential, your body's potential, into being able to perform the way it wants to perform. So, and we'll have you keep that in mind throughout this lecture. So without further ado, let's talk about, why you're here and why you're here to listen and want to listen is endometriosis. And so we're just this is a quick overview of what we're about to discuss, but, what is it? Understanding what normal function is, the causes, the way it's diagnosed, at least from my way of what I've researched, symptoms, facts, and then why is it so painful, and why is it so painful to me or you? So what is it? So this is my basic kind of layman understanding or layman definition of it's a condition and dysfunction where the endometrial tissue which normally is in your uterus, inside your uterus, is found outside, usually around sex organs, around your stomach, abdomen, and it behaves much like the walls of the uterus and the tissue, the endometrial tissue. So. And so it's really sensitive to the menstrual cycle and enlarges, and it kind of follows that. Whether you had a hysterectomy or not, it still kind of behaves in that cyclical pattern. And those are things we do want to keep in mind as we're helping address these patients in endometriosis patients' needs. And so that's kind of what it is. And this is a picture of adhesions that are usually in line. It kind of sets you up to what I was about to say next. But so, what if it isn't, just some people do believe endometriosis is hereditary, but what if it wasn't? And that's the question I do want to raise for you, and you guys can think about that. But what is normal mechanics? And I got a picture of a uterus and fallopian tubes and ovaries here. So what happens is when ovulation happens, the ovaries basically they approximate towards the finger-like cilia of the fallopian tubes. So those are this points right here, and they should come closer together to each other. And so when the egg is released, then it's really close to the fallopian tubes, then it'll migrate towards the uterus through the fallopian tubes. But in theory, basically natural movements, normal movements, walking, standing, moving around is the way to kind of passively move and migrate the eggs towards the uterus. But since we're in a more sedentary environment these days, then these are some of the things that I would call some traumas that would happen, whether they're major or chronic. And some of the chronic ones are, I think, the sedentary lifestyles, being at school, some of you still in school, and things like that. Not saying you shouldn't go to school, but these are things when you're ovulating, and this needs to happen when you're sitting where you're at. It would be interesting, right? That the pressure is so much that the ovaries aren't able to approximate the fallopian tubes. So that's something to think about. That's something I've found with many patients. So there's scar tissue that happens because they're trying to get closer and they're just getting irritated every time. So we'll talk a little bit more about that, but these are some of the things, like I said, skin folds and sitting posture. I tell people, use your fingernails and just as an instance, and you just put a little bit of pressure, and you can imagine what sitting's like. You're already decreasing circulation to this area, and you're depriving it of nutrients and hydration. So that's one thing to think about. And so another thing that people don't realize is that the ovaries, when you ovulate, they should alternate in a normal case from one side to the other. So some months are really bad for some women, and they just don't have no idea. Then other months they're fine. So it could be just one ovary and one side that's the issue, and you have to realize that if you really start thinking about it, it is sometimes that one that is more restricted, that alternates every other month, that gives some people problems or issues. And so dysmenorrhea, like I said, some people do believe there's some sense of being hereditary, but what if it wasn't hereditary? And these are things that we're doing to ourselves. So next one. Here's some quick overview of causes. There's a bunch. You can go online, and I just wanted to list them all, but I'm not going to rattle them off. But I do definitely want to talk about adhesions here. But these are some things I found and pulled off Google, whether it's toxins or surgeries and things like that. So there's just a laundry list. You can definitely, and some of you are probably more aware of it than I am. But and I like to think of this as, how does this diagnosis, endometriosis or label, affect you? So I want you to, and basically I kind of use label as wanting to look for, instead, something a little give we want to look for a deeper causal effect of why this is happening in here. So I just want you to think quietly to yourselves, and we'll give you a minute. But this is the question I really want to know when patients come to see me. How does it affect you functionally and keep you from living the life you want to live? So, you probably had some thoughts in your mind. And so we have to honor that everyone does come from a big different background. And back to my 6-point strategy is that, you all have different goals, and, what it is to you is your journey. And we have to honor that, and it is your own experience. Here are some symptoms. It includes but is not limited to these, but some of the big ones are, it's painful during menstrual cycles, painful sex, infertility in some cases, fatigue, bowel, and the list goes on. And then usually what we found is that many women with endometriosis also, suffer from, allergies, chemical sensitivities, and whether it's diet, food, and frequent yeast infections. And then here's more symptoms. So, this I took off curetogether.com off a survey. I think they surveyed a few hundred women off of this, but you can see that this is a laundry list, and the list just keeps going. And so I would say, if just seeing all this, you're bombarded with all these symptoms, I'd probably be afraid of my own shadow, just wanting to leave the house and things like that. And so I totally understand. This is a lot of stuff, to go through. If you have one or all, it's still quite significant. So here's some facts. the incidence here is there's roughly about 3 million new cases per year in the U.S. And I pull all this stuff off Google, like I said. And the real only way it is diagnosed officially is through laparoscopy. And what that is kind of what I said here, in a small incision. And what they're trying to find is, the exact location, the size, and the growths that happen there, whether it's fibroids or whatnot. But the doctor usually is the one that helps direct you and try to make some treatment decisions. And oftentimes I find that physical therapy is not one of the options. So that's one thing. Hopefully this video and even you guys being educated can tell others about that we do have some chance. So many live with a poor quality of life. And you're always seeking answers, whether it's conventionally, unconventionally. People will fly from, different states and different parts of the world to get help. And it's anything to get a solution. So why is it so painful? Sorry. Okay. So here's my theory, and I kind of just said a little bit about it. We do believe it's right here. All right. So here's my theory on endometriosis. I think, and this is, I'm going to preempt myself, before in the next, I think, 15, 20 years, research is going to come out, and I do believe a lot of chronic pain states are going to be inflammation or nerve pain related. And so I think a lot of times we have a lot of uncontrolled inflammation, which then creates more adhesions and more scarring. And so I think there's, inflammation is such a big balloon umbrella of different things that can just totally wreck a lot of parts of the body and really decrease our healing ability. So, I do believe that, things such as stress management, diet, manual physical therapy, of course I'm a little biased there, is that, those are great ways to help start managing them on a kind of more broader level. But I also, like I said earlier, sitting, lack of movement can be an issue. And I do believe that restrictive garments, I do believe that, when I was growing up in the 80s, I am dating myself, but in the 80s, my underwear, my elastic waistbands weren't very good. They weren't as good, but I think that was probably better for us. I think the material these days, the elastic waistbands in our exercise clothing, compression shorts have really made things more restrictive. And I kind of go back to that fingernail issue with the nutrition, poor nutrition towards that area, because our body, our skin needs to breathe, and so that's when adhesions start happening. So I was totally excited when Under Armour came out with compression shorts. This little story, and I loved wearing it. I felt so supported. It was great. I felt like I was running really fast. However, after about 6 months of wearing it, I do believe that after about 1 minute of running, I always had to go to the bathroom, and then I went to my visceral, and I was like, why is this happening? Every time I start running, I'm like, God, I gotta go. And so about a month later, I went to see my therapist who does organ manipulation, and we found a lot of restriction there. I'm like, why is this going on? My question is always, why is this going on? And I was like, how am I getting this? And it wasn't. She was freeing out, and I was feeling scar tissue release. And I was like, what if it is this tighter elastic waistband that is out there? And for women, they're undergarments and bras, and the yoga pants and stuff that everyone's wearing. I think these things there might be something to it. I don't have any proof. This is just my theory, but just give you something to think about. Here's some little pictures I took from the Journal of Endometriosis in 2011. So those are scattered throughout the lectures. Yeah, and then so, like I said earlier, this is kind of why I think it is we feel what we feel, and these adhesions are really some of the big issues. So let's just go back, and why is it so painful? Let's talk about connective tissues in general. I think if you understand connective tissues, they more or less, they lengthen and they shorten. And I always tell my student interns that if you can figure how to make something that doesn't shorten, something that doesn't lengthen, you'll be more successful as a physical therapist than 90% of the people that are out there, right? So let's kind of do another demonstration. I'll have you guys stand up. And so So let's talk about lack of lengthening, and that's what I tell people. I usually ask these little qualitative questions. It's a stretch feeling, you know? And so if you basically, you know, took your jacket or your shirt right now and just kind of pulled it, and then you try to walk away, you know, you're feeling like a stretch feeling, right? It's just not there, right? You know, it's like something that's, I want to go that way, but it's not happening because something's pulling me behind. And then the other one is the blocked feeling, and that's like an adherence, something that's in the way. And you know, you can use your arm on the other side, and you're still trying to go that way, but you know, there's something else that's blocked. And I basically use some analogies like the wall. I'm like, I can't. You know, I want to go there, but it's not going to happen. So our tissues do need to shorten and lengthen, and just kind of have that as a understanding of, you know, even going back to my 6-point strategy. You can all have a seat again. So here's a case study, and this is one of the patients, a 39-year-old female came to see me, and there's some background, some history. She's had a vaginal birth 2 times and had 2 beautiful daughters. From her childbearing, and then in 2012 she had endometriosis and then subsequently a hysterectomy. So her symptoms when she came in were, as she stated, flare-ups, and it would be abdominal bowel pain. She would call them flare-ups. And what I noticed on my end, there was basically this pressure belly, which I would call it pressure belly. It's basically swollen and more or less like squishy, and it's just a swollen. It doesn't feel as, you know, like healthy, resilient tissue. And then she also had complaints of swelling in the ankles and shoulder pain, and then 7 fibroid formations. She would often, I'd ask about sleep, and then she would say she got 8 hours of sleep, or she was in bed for 8 hours, but it was oftentimes never restful or productive sleep, or, you know, regenerative sleep. And then she does believe that diet is sometimes a cause of the inflammation. Even though she had a hysterectomy, I do want to note that, you know, like I said before, that endometrial tissue follows sometimes the cyclical menstrual cycle. So even though you don't have the physical structure there, everything is more or less still triggered by the brain. And that's a very important thing as we go on and as I talk about how I went about treating. So these are some functional life losses that she has mentioned. You know, just kind of loss of enjoyment, withdrawal, work, intimacy, family relations, and even in her community. So, and that's a really important part of what it is for her. So, so how do we help her? And so within 10 visits, we did have 10 visits together. My goals for her in that 10 visits were to basically take on accountability, have extensive ownership of exercises and posture and things like that. Those are tasks I wanted to go after. We wanted to decrease and manage inflammation, and you know, we try to go different ways, whether it's, you know, to decrease stresses, talk about, you know, deeper breathing and meditation, and work on the internal stress or external physical stresses that can also bombard the system. So anything we can do to get rid of these stressors, whether it's, you know, being in a car too long, sitting, or, you know, these are things we want to try to manage. You know, that's the best way we can do. Want to educate her and train on her core, her stomach. We'll talk about the core in a little bit, and why that improves function for those with endometriosis. We want to, you know, like I said, adjust the car, and church and work, and then decrease those irritable habits. So, you know, why I believe this could all work, and like I said, I wanted you to talk about and introduce the 6-point strategy earlier, is our goals with the strategy. And then, you know, I think what happens, like I said, it's a thread and it's holistic and it covers the bases, and really what it gets down to is that performance, that function, and then function is really what I'm trying to point out. So let's go back to that first point on my 6-point strategy, internal mobility. So the things that we wanted that I was intentionally looking for were her nerves. I wanted to understand, you know, the lumbo lumbopelvic, lumbosacral plexus. And what we wanted to do was, I wanted to get in there and free up whatever adhesions that were limiting the ability for the nerves to slide and glide. And then the vagus nerve, and so that's that going back to the whole idea about the brain, and it does affect, on on this picture, all these different organs: your vision, your adrenaline, your heart rate, your blood pressure, your digestive system, all the way down to your sexual organs. So you can see how big that effect is. And if you don't address this, and there's ways to manipulate this externally that we do go over. There's so many things that are out there that people just live with, and it really does debilitate a lot of your lives. And then we talked about the visceral mobility and motility, and after the surgery, I wanted to kind of time this around menstrual cycle too, and work my when the menstrual cycle was happening, even though she didn't have a uterus. Is the scarring that was around there, because I wanted to get a better understanding. I want to learn her body a little bit better and understand how bad was bad, right? So and then want to work on those restrictions around the bladder and the rectum, the colon. We could do that externally. We don't have to do that internally. Some people do internal manipulations through your anus or vaginally. So let's talk about external mobility. And a big thing here about external mobility is, kind of going back to that tissue shorten and lengthen, that, they need to slide, glide, roll, and spin past each other. These nerve bundles, these bundles not nerve bundles, sorry, the muscle bundles, the muscle fascicles. So we call this, my mentor has termed this as play, as muscle play, and I kind of taken this a little further. I call it tissue play, but I wanted to give him credit, my mentor Greg Johnson. And we do believe that this enhances this ability to kind of decrease the external forces, the blows that happen to our body, the ability for it to slide past each other, and like our little demonstration earlier. And we want to strive towards to be more efficient there and more optimal, which is most everyone's physical therapist's goal in general, but we want to go there, and we want to go specifically and treat the thorax, abdomen, and pelvis. And I learned under one of my mentors, Diane Lee, I have to give her credit as well for really painting a better picture of the diaphragm and its importance for us. The diaphragm is innervated by cervical roots C3, 4, 5. We say 3, 4, 5 keep you alive. Really important, and we want to ensure that there's mobility there. What happens here's the diaphragm here, and you can see it's kind of the floor for the heart, but it is the ceiling of what we call the core. What we like to think about the core, it's not just the wall, the six-pack muscle, but the core itself is the ceiling. And we want to think of it as Dr. Mary Masri would say, is like a can, and like a little can that you have here. The diaphragm is the top, the pelvic floor is the bottom, and around the wall is that transverse abdominis, your oblique muscles that encompass it. So what happens there biomechanically is when you're inhaling, your diaphragm flattens, and what that does is it kind of starts massaging the organs. So a lot of people have problems breathing. They're not breathing. A lot of people with endometriosis aren't breathing very well. So I want to reinstate those things and really get these things, because when you can massage the organs and they can then move. We're creating that passive mobility or motility, which is the way the organs move. So with that said, after I started looking at these things, I wanted to look at, kind of, does she have this neuromuscular reflex and response? And I'll have my interns come up and help demonstrate. Well, I'll actually all of you guys stand up and again, go and find a partner, probably pair up if you can. And but this is great. I'll have Vivian and Stephanie come and help. But this, even with the optimal internal and external mobility, we need to, like I said, it's kind of that whole like AOL versus that broadband way. But you're going to face your partner like this. They're going to show you. One leg's going to be, you're going to kind of, and then the opposite person mirrors it like this. Yep. And so if you guys take a look there, yep, you want opposite. We want to see if you have neuromuscular response or neuromuscular reflex, that ability to initiate. Okay, and then what you're going to do is one person, just pick whoever wants to do this, you're going to have your arms extended. You should be about arms extended. You should be able to straighten your elbows. Okay? And you're going to be very nice to your partner, okay? I don't want you to throw them across the room. But what Stephanie's doing here is she is going to use her stomach muscles and just lean in. And when you lean in, you want to see if that person can hold their balance, you know, and that's really important. Can they hold their balance? And then you push until they can't, and then stop. But, you know, what happens is if someone has a good response, they're able to stick their feet into the ground like tree roots, and you can't move them. That's a good core response. And, you know, a lot of people with, you know, chronic pain, a lot of people with, you know, abdominal, visceral pain, they can be moved. Go and switch partners. Go and switch sides. And, you know, and so we want to see if that's efficient. And this sometimes may even evoke some pain in some of you. But you see, like, do you really have that ability to withstand external forces? Is it available? Is the capacity there? Great, great. I'll have you sit when you guys are done. But yeah, you probably can see, like, did my core kick in? And if those of you felt it, their stomach kicked in automatically. They didn't have to think about drawing it in. Thank you, guys. They didn't have to think about drawing it in. And that's a really important thing, is that it's automatic. This automatic core engagement, as one of my other mentors, Vicky Saliba Johnson, was able to coin. So with this patient, she had no neuromuscular reflex. I pushed her over and she basically fell. And it was just like, okay, this is what I have. So we definitely want to get those stabilized. And then we wanted to move on, like I said, and address static dynamic performance. And, you know, we had to go through like educational pieces, and I have videos online. I have a YouTube channel online, and we'll give you that information later. But you know, we wanted to address how to walk, how to stand properly in good posture, how to sit, how to sleep, how to be in the car, how to sit to stand, and many more different functions. Because those are things you need to pick apart, because like I said, any little thing can increase the stress and inflammation in your body. And if we could address all those things and start getting to the point, you know, getting that umbrella effect, then, you know, we hope, you know, that all or maybe one of them is the reason that these things keep flaring up or these symptoms keep coming up. So here are our non-medicinal and non-surgical solutions. So we basically, like I said before, we wanted to improve habits, posture, wanted to implement a good core regimen in her program, and do some pelvic floor conditioning, work on that diaphragm. That's so important. Like I said, that diaphragm is so key. And then keep going after biomechanics and function and how it functions. We wanted to free up the scar tissue manually, and we wanted to get the nerves to glide, like I said, and just educate her on you know, proper inflammation. We even were able to get her some lymphatic work to get the lymph system is great. Like I call it the sewage system of our body. We were trying to get the sludge moving, and so some people may have gone and got those things, but like I said, we want to encompass it in a whole different model of thought process. And then really what I think is the most important for those with chronic pain, and this is what I always say, be a pain manager. Don't be a pain victim. And that's a big thing, you know. We're so powerless when we're victims, but when you're a manager, you are now the one in control. And that's what I want you guys to go home, go home thinking about today. So in the 10 visits, were we able to accomplish these things? And I think we were able to do a pretty good job. And she came once or twice a week over the course of 3 months, and then she moved on to maintenance for once a month. Maintenance plan, and where she is today. She's mentioned to me before that, you know, she couldn't imagine being able to fly to places like China and going to China and India. She's able to hike the Great Wall of China, and she teaches a caseload at a local university. In the time I've known her, she's been able to author 2 books, which is pretty amazing. You know, being a happy mother, wife, family member. I think that's what, you know, it's really all about. You know, is to get down to those important things and really be a contributing member in the family and in society, and just feeling more control. She even mentioned one of the last times that it was well enough to feel like she could jog and jog around the block, and even for a few minutes. That's pretty amazing. And you know, and right here, the view from the top, she was just recently able to climb a strenuous mountain. And thanks, Pyle, for being able for us to share your story. story here, and I appreciate you coming today. But this is great, you know, like this is living the dream. This is what I call it. So yeah, I'm really excited that, you know, she was able to introduce me to here, and so, like I said, I have a book, and in my book, I call it Rehab the Mind, Revive the Body, and it's Foundations of Healing, and it's more of it's a narrative book, you know, and it's basically if you're looking for a paradigm shift in our modern way of healing and treating ailments, you know, my book is about hope and courage, and in spite of our labels, our pathologies. You know, I don't want you to be bogged down, you know, with labels. There's a bunch of people with labels inside my book, and I think, you know, Pyle could be very well, you know, a person in my book. So I kind of like this quote after, you know, there's that billion dollar lotto thing, and Mark Cuban said something interesting. He goes, if you're unhappy before you have the $1 billion, you're gonna be unhappy, you know, after the $1 billion. So it really doesn't matter. You have to work on your mind and your spirit and your, you know, kind of your attitude towards this. My take home for this lecture is, you know, to promote movement again, you know, and implement a plan of action and work towards, you know, a belief system of hope. And that life can and will keep on improving, you know, and you can do this by being proactive. I do believe there's a few points that you want to, like I said, being proactive. I think some of it, a lot of the times, is that emotional barrier. Is you got to get rid of the shame, the guilt for having some of this stuff that I know that many people have. But and then, like I said, being a pain manager is really important, and not a victim towards inflammation, towards stress, towards nerves, towards this label, towards this pathology. You know, and some of us have had, you know, depression and just, you know, different labels. But, you know, once you get over that hump, then you have to ask yourself, what's next, right? You know, what's next is to revive. So that's our hashtag. You know, and you can, you know, hashtag us whenever you feel like you feel like you're on the reviving path. I just put this thing here. I guess. This is also from that journal of endometriosis as well. And then here's some resources. And stay connected with us. We have little flyers as well. We have a YouTube channel. I put out stuff every Monday and Thursday, whether it's understand pain or exercises, and so it's a pretty good thing. And then we have Pinterest, Facebook, Instagram, Twitter, all this fun stuff. And if you need to reach me, you can find me either on the net, but my email is usually pretty available, and you can hashtag us as well to revive. And then our handle is at Rehab and Revive or hashtag Rehab and Revive. Yeah, that's it. Thank you so much for having me. And if you guys have any questions,